Good afternoon. At the outset, I'd like to thank the organizers to giving me this opportunity to speak in front of this August gathering. So I'll be speaking against the motion, all SGLT2 inhibitors are same. We all know this. One size doesn't fit all. So before going into this topic, I'd like to share this point that comparison of trials should be interpreted with caution due to difference in the study design, population and methodology. And each of these studies which have been mentioned by my earlier speaker, they are basically placebo-controlled studies. There is no head-to-head comparison between the different SGLT2 inhibitors. So we lack the data, and most of these comparison came from meta-analyses that have been used to indirectly compare the effects of different SGLT2 inhibitors, but the analyses are limited to the different indirect comparisons and potential for bias. And some meta-analysis used Shukra scores to rank the SGLT2 inhibitors based on their probability of being the best treatment for specific outcomes. So, as this was previously said, that there was hardly any difference among the SGLT2 inhibitors regarding their pharmacokinetics. We all know that bioavailability are more or less similar, but with the highest bioavailability for Dapagliflozin and lowest with the Sotagliflozin. Half-life remains same, metabolism remains same, but predominantly they are excreted by urine, and except Dapagliflozin and Sotagliflozin, they are excreted by fecal route predominantly rather than urinary route. So dose adjustment is not a concern for the drugs, except based on the trials. We prefer to use Dapagliflozin when the GFR is more than 25, Empagliflozin when GFR is more than 20, and Canagliflozin when GFR is more than 30. But we have to remember that at low GFR, the efficacy to reduce the diabetes because of the low renal function and the low tubular function, the SGLT2 inhibitors lack their efficacy in low GFR state. And regarding the HbA1c control, not all the drugs have similar potential. We can see that Canagliflozin has shown the greatest reduction in HbA1c reduction in some studies. So as far as the glycemic control is concerned, Canagliflozin and Sotagliflozin works fair well when compared to the other drugs. However, the weight loss and BP control is similar in all the drugs. If we compare these drugs regarding cardiovascular benefits, specifically if in atherosclerotic cardiovascular diseases, we can see that in the previous, as my previous speaker said, that there was hardly any difference. So he was again thinking that whether there are any difference exists or not. See the trials, see the evidences. All these cardiovascular outcomes which have shown the superiority of these SGLT2 inhibitors over placebo is because of the heart failure reduction, reduction in the hospitalization rate due to heart failure, not because of the atherosclerotic cardiovascular diseases, where these drugs are basically either non-inferior or there are insignificant data. They are, even if the data are available, they are not statistically significant. So here Empagliflozin works fair well over the Dapagliflozin as far as the cardiovascular, atherosclerotic cardiovascular diseases are concerned. So these studies, all these studies like EMPAREG, CANVAS, DECLARE-TIMI, CREDENCE, VERTIS, among all these trials, Empagliflozin have shown better efficacy when they are compared regarding the cardiovascular death. And Dapagliflozin did not result in lowering of major adverse cardiovascular events than placebo. Among the patients with established atherosclerotic cardiovascular disease, the MACE was 13.9% in Dapagliflozin group and 15%. So there is hardly any difference with the placebo. Among the patients with multiple risk factors, again the rate was comparable to placebo. So if we are concerned with a patient's atherosclerotic heart disease, choosing dapagliflozin is probably not, we are not doing fair judgment to the patient. Regarding the heart failure, that the drugs have been compared in Emperor reduced for empagliflozin and DAPA-HF for dapagliflozin. The risk of cardiovascular death was 8% lower in empagliflozin with the placebo and 18% lower with the dapagliflozin in DAPA-HF trial. But with those patients with prior myocardial infarction, it was 41% for empagliflozin and 8% only for dapagliflozin. Here also empagliflozin is doing better than dapagliflozin. So Emperor reduced trial, these patients were selected on the basis of reduced ejection fraction and increased level of natriuretic peptides. So consequently, the incidence of this primary outcome was approximately 40% higher in Emperor reduced trial than DAPA-HF trial. And also, DAPA has shown its efficacy better when they are being used in patients with heart failure with NYHA class 2 rather than NYHA class 3 or 4. Empagliflozin has also been studied in patients with preserved ejection fraction in Emperor preserved trial, and that has also been recommended in patients with both reduced and preserved ejection fraction. This meta-analysis has said that empagliflozin was associated with greater reduction in all-cause and cardiovascular mortality. And although the difference in efficacy of individual SGLT2 might reflect the different trial design, clinician may prefer to empagliflozin over the other SGLT2 inhibitors. Again, this meta-analysis is saying canagliflozin is most effective reducing the MACE and heart failure hospitalization rate, and empagliflozin is most effective in reducing atherosclerotic cardiovascular diseases. So if we compare, we have definitely the edge of empagliflozin over the other drugs as far as MACE is and atherosclerotic heart disease are concerned. For renal outcome, they have been studied in different trials like Credence, DAPA-CKD, EMPA-Kidney, and these trials have been designed in such a way some patient population have been excluded. Like in Credence trial, non-diabetic patient populations were excluded. In DAPA-CKD trial, polycystic kidney disease, lupus nephritis, ANCAS, associated vasculitis patients were excluded. EMPA-Kidney trial, polycystic kidney disease patients were excluded. So if we are using these typical molecules in those patient population, we are probably not doing justice to our patient. So we have to be selective. So does all these SGLT2 inhibitors perform same? No. Renoprotective effect has not been shown by R2-gliflozin or sotagliflozin. And when empagliflozin is used in patients with low GFR patients and patients with very high proteinuria, they do fairly well better than the other SGLT2 inhibitors. So again, as far as the renal protection is concerned, maybe dapagliflozin, EMPA and CANA are doing fair well to all those patients except R2 and SOTA. The risk of amputation has been shown in CANVAS trial by the use of Invocana, the canagliflozin, and black box warning was given. But later on, Credence trial and EMPA-Kidney trial did not show any increase in amputation compared to placebo. However, we have to monitor these patients for any incidence of leg ulcers or amputations which may lead to amputation in future. So finally, we should not talk about the costs of the therapies if we are debating with the data which are derived from the trials done with innovators. So to summarize at a glance, as far as the CV mortality reduction is concerned, empagliflozin does fare well compared to others. Heart failure hospitalization, mostly they are equal. CKD protection, based on dedicated trials, they are probably equal, but EMPA does fare in patients with very high proteinuria and low GFR status. As far as reduction of HbA1c is concerned, Canagliflozin and Sotagliflozin are the best drugs among these others. Safety, both are safe equally. Based in low GFR, EMPA does fare well and DAPA also does good compared to others. So the key takeaways are, as far as the Empagliflozin is concerned, it has best mortality data in CV outcomes, good renal protection. Dapagliflozin, strong heart failure and CKD data, they are very safe. Canagliflozin, it's powerful glucose lowering agent and CKD protection, but we have to be watchful for any amputation or fracture risk or leg ulcers based on canvas trial. Dapagliflozin is effective, but no additional cardiovascular or renal benefit has been shown till the data, whatever data we have. And SOTA is emerging with an additional effect on SGLT1 with a more GI side effects but promising heart failure data. Thank you.